once again, we may have angulation on the tube. So, we just rest there for a minute. How do we determine how much angulation we want on this tube? I know that in clinic, all your techs default to doing 5 degrees cephalic. But if we were trying to be optimal, how do we determine how much angulation to put on this tube?
Does it depend on the body habitus?
It does somewhat depend on the body habitus. What does it say in the notes? Did you get the notes I sent out? Yeah.
Internal rotation.
0 degrees, 3 to 5.
Okay, so we need to measure some stuff, right? So we have this thing, it's called a caliper. This lets us measure, right? We've got inches and centimeters here. So we can measure off this. What part of the patient's anatomy are we going to measure? What?
The side of ACEs?
The as is, very good. We're going to measure the as is, and based on the size of the as is, we are going to determine our angulation. So Javier, you could lay all the way back, please. Just lay flat. Just lay back flat. Relax on that pillow. So, where is the as is? Do you remember? Right by that iliac crest, right in the front of the hip, right? So let's see, where is your hip? Ah, okay. Nice prominent as is right there. So, we have our caliper. Okay. Just going to put it right here on that as is, and we're going to check our measurement. Okay. What is that?
16.
16. So, if the as is 16 centimeters, what angulation do we use?
3 to 5.
3 to 5 in which direction?
Caudal.
Caudal. Right, so for Javier, because of his body habitus, we would angle 3 to 5 degrees caudal like this. Oh, that's good. I appreciate it. I appreciate it. Right? So we can angle 3 to 5 degrees caudal like this. Okay.
Can I ask why does it go based off the acid?
So, depending on the size of the hip here, that is going to kind of determine what angle the leg is going to be at, right? So, on your average patient, right, if the leg's going to be perfectly like this, we can come straight through that knee joint space. If the patient is thinner, right, now the hip is going to come down like this, you need to angle caudal. If your patient's thicker, leg angles like this, you need to come cephalad to come through that knee joint space. So the whole point here is to try and get through this knee joint space based off like the tibial plateau, based off the femur. Okay. For the knee is the first one where we really need to consider doing this with grid. Right? Everything else was tabletop, but this is the first one where we want to consider using the table bucky instead. For Javier, he's thin, we can probably get away with still doing this tabletop, but for your average patient or for your larger than average patients, you do want to use a grid. Okay.
For test out, do you want us to do it in the grid?
For test out, yes. For test out, I will want you to do it in the grid. Okay, so regardless of your patient, I will want you to do this in the grid. Okay, remember, we are going to be putting this portrait. So how long is the cassette?
10 by 12.
Okay, how long is this one is portrait?
12.
12. So 12, you put this at 12, you put this at 12, you put the cassette inside, right? Make sure that both of your leaves here are 12. Okay, push it in, make sure it clamps. Don't try and clamp this early. Push it all the way in, let this clamp tight. Okay. And so we are going to be using our 3 to 5 degrees cauded. Let's see. Okay. Leg nice and straight. We want this long axis lined up with the long axis of the table. where do we center for this one? This is the AP knee.
1 inch distal to apex of patella.
1 inch distal to the apex of the patella. Very good. Where is the apex of the patella?
Bottom portion of it.
Very good. The bottom portion, right? So don't get confused. Normally we think of apex as top, base as bottom, but the patella is an upside down triangle. So base is at the top, apex is at the bottom. So luckily we have a really nice patella that we can palpate. So we've got the apex here. Gonna go down, right? Gonna go down half an inch. Oh, I have this locked this way. Actually, I'm gonna make use of my table, the rest of my table as well. Okay, since we are in the bucky, don't forget to line this up, right? Since we're in the bucky, don't forget to make sure to fix your column inch or fix your SID. Oh, that's why. And don't forget to fix your detent as well.
Detent.
Do you use the angulation for every conjunctivity?
Yes, you do. So you leave this specific angulation on for your AP and your obliques. The lateral will have an angulation as well, but that is separate from this one. Okay. So, right, we have green light. We need the green light now because we are working inside the bucky. All right, careful, I'm going to slide towards you. Okay.
Yeah, no, you're lucky. You don't have to measure the side of Javier's
No, I think so.
as
Oh.
No. But he very relaxed, right?
that's why.
You never know, it might, it might change. You might suddenly put on some muscle in the gluteus.
Next 2 weeks?
Let me eat first.
Okay. Right, so we're gonna, right, apex of the patella, go down, half inch.
See? Daniel, you're lucky.
So for this one, we want to get a good AP. So how do we get a good AP? We're gonna try and get, actually, let me just double check this. Javier's has to wait a little bit. So the knee is going to be similar to the elbow, right? So if you feel this femur here, right? You feel the femur, you come down, you suddenly feel this prominence, right? What is that? 15 degrees? Oh, okay. So if you're following the femur, you've got this prominence right here, right? So at the proximal end, you have the epicondyles. At the distal end, you have the condyles. So much like with the elbow, we're going to feel for these epicondyles and try and get them lined up. Okay, so we want these parallel to our IR. Okay. So rotate slightly. Good. Okay. Now the reason why I say Javier's anatomy is a little bit unique is because normally when you line up these epicondyles, the foot will be either straight up or slightly internally rotated. Okay, but however with him, his foot is externally rotated. That is fine, right? The main thing is, just as long as you have these epicondyles lined up, you are going to be in a true AP. So all of our measurements here, all of our angulations, when we do our obliques, are going to be based off these epicondyles. Okay, for our collimation, right, we're going to open our collimation up vertically. Right, so our 10 by 12, we do want to try and make use of the full cassette. So get as high and as low as we can. If you are working with a 14 by 17 cassette for whatever reason, and you're doing a knee, please do not open it up all the way. Okay, we do not need 17 inches of collimation for the knee. Keep it to 12 inches. Okay, horizontal, we're just going to come down here to the skin spaces, and then we're going to take our marker and put it here on the lateral side.
For the collimation side, do we need to do the 1/3 of the
So-
tibia, or just like
So just
randomly?
just have it open 12 inches
Oh,
to the borders of your IR. If you're doing a 14 by 17, don't go all the way open, just keep it around 12 inches.
okay. Fair.
Now, if you've got like a really small patient, then yeah, you can afford to collimate in a little bit. Okay. But typically, right, we do want to make sure we catch the whole patella on this, plus a little bit more, and then however much we go down in the tibia. Okay. So for the knee, we also have two obliques, just like with the elbow. We have the internal, the medial rotation, and we have the external, the lateral rotation. So let's go ahead and start with the medial rotation. So we're going to turn your foot in. Perfect. And our whole goal here is to try and get this epicondylar line, right, 45 degrees now, medially. Right? So very good, just like that. Just going to slide you to make sure you're still in a nice straight line. Okay. Very good. Okay. For most patients, when you do this, the foot is going to be actually almost fully lateral. It's going to be a very big internal rotation of the foot, but when you measure this epicondylar line, it's only going to be about 45 degrees. Okay. All right. Once again, we're leaving our angulation here. Right? We're not changing this angulation. It stays the same. All right. Let's go ahead and do a lateral rotation externally. Good. Okay, we're going to be checking this epicondylar line, but now the opposite direction. Right, so we want it 45 this way instead. So yep, you were good, Javier. Yep. All right. And I'm just going to slide you back a tiny bit so that you're centered. Throw the marker right there in the light field. So we're still centered right down the middle of the leg at a level half an inch distal to the apex of the patella. We still have our angulation on the toe. Just half an inch, right?
Yes.
Good. All right. So finally, we have probably the most difficult knee projection, which is the lateral knee. Okay, so Javier, I'm going to have to turn all the way onto your side. Okay. Now, with a lot of the old school texts, this is what you're going to see. Going to bend your knee. All right. Right leg in front.
Yes.
Okay. A lot of old school texts will position the knee like this.
Oh.
Okay? Now, Bontrager's still keeps it the other way. So we're going to have this leg in the back here. Right? Either way will get you the images you need. Right? But since we are following Bontrager's, we're going to do it Bontrager's method.
For that, does it matter?
Um,
I mean, test that, I'm sorry.
For Testo, like we're gonna try and follow Bontrager's, but in clinic, whichever way you want to do it. So our main goal here is once again to get this patella perpendicular to the IR, to get this inter-epicondylar line perpendicular to the IR. Okay, so we're going to just take a look here. Turn him just a little bit, Javier. There you go. Okay. This time the knee does not need to be bent 45 degrees. Right? You can straighten this out a little bit more. Right? So something like 10 to 20 degrees is acceptable. Go, just turn your leg, turn it a little bit more towards me. There you go. Right. Main thing is make sure that this other leg does not end up superimposed on top of the area of interest. Okay. Where do we center this time?
1 inch distal to
What?
medial epicondyle.
Good. 1 inch distal to the medial epicondyle. Right? So we feel for that medial epicondyle here, and then we are going to go 1 inch distal. Right? So we take a look, right? That's going to be right there at that knee joint. Now, earlier I said that we had an angulation, right? So, what is the angulation for this lateral knee?
5
5
to
to
7.
7.
Yes.
Cephalic. Right, so regardless of your patient, you are now going to be going 5 to 7 degrees cephalic. Okay. Why is that? Why do we go 5 to 7 degrees cephalic?
The joint space.
The joint space, very good. It's always above that joint space. So what's so special about the femur that we would need to go 5 to 7 degrees cephalic? Well, the thing is that the condyles down here are not flat. Right? If the femur is flat like this, the condyles are actually at an angle. And that angle is about 5 to 7 degrees. So we're using that to sneak straight through that angle to get our joint space. Okay.
I have a question about the leg. This leg here move forward for the old school. It impact to the image quality or just doesn't matter?
It's just a positioning. It just helps with positioning.
Okay.
Right. So this way, if you do it like this, right, this right foot can kind of help brace from the back. If you do it the old school method, come forward. This makes it easier to get a good rotation, and you're going to brace the patient's leg from the front. Okay, but either way, you're still going to end up with the same looking